let's go ahead. Scenario 2, are you guys ready? Okay, so a 59-year male presents to you with dizziness, headache, sort of double vision, nausea since early morning. He took paracetamol, no relief to the chest, the headache. He stated that he is hypertensive and he did take his amlodipine 5 milligram this morning. His vital signs are his blood pressure is 190 by 128, the pulse is around 88, respiratory rate is 18, SATs are 97% on this here. What do you think about this case? How would you manage this case? And what could be the differential diagnostics? Okay, I'm going to give you a minute's time. It's 6:24 here. So 1 minute time for you guys. Anyone? What are you thinking? Okay, patient's got a headache. Patient got a double vision. Patient got a dizziness. On top of it, you can see that the blood pressures are quite high. Yes, it could be accelerated hypertension, hypertensive emergency, great. So the main difference for us is to differentiate whether the patient has a hypertensive urgency or emergency. Urgency, they can go home. Emergency, they stay. End organ damage, emergency. No end organ damage, urgency. Emergency, IV medications. Urgency, oral medications. As simple as if you want to, weigh them, how to treat them. So for this patient, for special interest, if you see there are few red flags in the signs: double vision, dizziness, high blood pressures. Okay, what could be? See, the reason I'm emphasizing, yes, good, Dr. Kushwa, stroke. A posterior circulation stroke may typically present like this without any obvious arm weakness, speech slurring, or anything. And we may miss this thinking, oh, the blood pressure would have been elevated, give some antihypertensive to the patient and send home. They'll come back again in a day or two once, the cerebellum cortex has swollen to a point that, they're having difficulty in swallowing, they're just not themselves. So yes, this has happened, I guess, with most of us. If not, avoid getting into this situation, because to me it has happened once. Okay, the patient did not have any obvious neurological signs. He came back the next day, we did an MRI on him, he had a very, very small cerebellar infarct. So how do you proceed ahead with this? So if you're sitting at a periphery, again, as I say, just use the Cincinnati pre-hospital scale. So it's basically fast, whether your patient has a facial droop, has an arm weakness, has a speech slurring, and note the time of the onset. But we as medics would like to do something else, isn't it? So always check for AVVV. AVVV stands for ataxia, vertigo, vomiting, visual disturbance. This patient in particular has vertigo, nausea, we may count as vomiting, and visual disturbance, which is very, very typical of a posterior circulation stroke. How would you approach this patient now? Let me minimize this. Okay, as I say, A, B, C, D, E. Okay, if the airway is patent, great. Is the SATs fine? Great. Patient breathing well? Great. Circulatory parameters, he looks quite unstable with his circulatory parameters. Get the IV line and send his basic bloods, get the ECG to make sure, we see if it's not MI, it's not dissection or anything that's mimicking this sort of presentation. And establish the time of onset. Usually these cases would be treated by neurologist, a stroke specialist. So if you are not a stroke center, refer the patient to a stroke center. And what do you do immediately in the ED? As you can see on the screen, in the initial 10 minutes, you must assess the patients, check the ABCs, vital signs, as I said, give oxygen if indicated, get IV lines, blood glucose. While we were talking about, for instance, a patient comes with all the neurological symptoms, but still snoring, not responding to you, just don't jump in assuming it's a stroke. Always check for blood sugars. It just takes 30 seconds to get a blood sugar, but make sure you make it in your habit to get the blood sugars. Do a basic primary neurological investigation. No one is going to ask you for doing the 12th cranial nerve exam here. It's just whether the patient is awake, alert, having any sort of hemiplegia, what's the pupil size like, what's the gag reflex, basic thing. And then you can order with the CT with contrast or the MRI scan if you have. And once you've sorted all these examination part, your CT scan, not very, very conclusive, but your MRI, for instance, you managed to get an MRI and the patient does have a cerebellar infarct, then you'll have to go for thrombolysis. Okay, so the other important thing of having like the advantage of doing a CT scan over MRI is CT scan is fast. It will help you differentiate whether the patient has a hemorrhage or not. So most of the centers would still use CT scan, and if they don't see any signs of hemorrhaging, they still thrombolize the patient. The only trouble with CT scan here is you don't get to see the what's the penumbra size, so how's the overall going to prognosis be like. But trust me, even in the UK, we do not use MRI to exclude whether patient has a stroke or not. If they're presenting with clinical signs of stroke, there's no obvious contraindication for the thrombolysis. We do thrombolize patient here as well without the MRI. Yes, no hemorrhage, clinical signs of stroke, thrombolize. Okay, so if the patient, for instance, has a hemorrhage, then you need to, basically go and have a chat with the neurosurgeons and plan basically, because this patient is going to deteriorate very fast. So if you need to put an advanced airway, go ahead. If you need critical care input, go ahead. If the patient, on the other hand, does not have the hemorrhage, you need to thrombolize this patient. So we need to give RTPA to this patient. Be very aggressively in treating the blood pressures. Don't be very, very aggressive. That's what I'm going to say. What happens is most of us would randomly give any hypertensive to the patient so that the blood pressure comes down. We should not, play with the auto-regulation mechanism of the brain, basically. So the blood pressures has to have a set target of systolic should be more than 100, and diastolic more than like 100 or something like that is more than happy for everyone else. So once we have made sure that a patient is thrombolized, either set them to the ICU care, or if you're not able to keep them with you, have a close watch for the next couple of hours, because if they deteriorate, this is the time when they do. So unconscious patients, patients coming with any signs of ataxia, vomiting, vertigo, think about posterior circulation stroke.